Hello, welcome to the Center for Connected Health Policies, Telehealth and Medicaid, a policy webinar series. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, and today's topic will be talking about Medicaid Telehealth Policy for Children and Youth. Next slide, please. A few disclaimers and friendly reminders and housekeeping items. Please know that any information provided in today's talk is not to be considered legal advice. It is strictly for informational and educational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. Also know that neither CCHP nor our speakers have any type of relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services that may be discussed in this program. Today's webinar will be recorded and slides presented here will be made publicly available on CCHP's website at cchpca.org or through the CCHP YouTube channel. Additionally, please note that closed captioning is available. There is a closed captioning button on your toolbar at the bottom of your screen. We also ask that attendees please refrain from political statements or advertising commercial products or services during the webinar. Your cameras and mics have been turned off. If you have a question for a panelist, please utilize the Q&A function. If you have a technical question about Zoom, please utilize the chat. Next slide. A bit of background information on CCHP. We were established as a California Telehealth Policy Organization in 2009 as a program underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center became available through a grant from HRSA in 2012. CCHP applied for that, we received it, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal level on connected health and telehealth projects. We act as the administrator for the National Consortium of Telehealth Resource Center, which is made up of the 14 telehealth resource centers who are funded underneath the same grant program as CCHP. There are 12 regional resource centers that cover specific states and 2 national centers, one on policy, which is CCHP, and one on technology. We are also the convener for a group in California called the California Telehealth Policy Coalition, which is made up of over 100 statewide organizations interested in advancing telehealth policy in the state of California. Next slide. This is a map of the National Consortium of Telehealth Resource Centers. The 12 regional resource centers cover specific states. I encourage folks who are interested in telehealth or have telehealth questions, how do you start a program, policy questions, to first reach out to your regional telehealth resource center, but know that all 14 work very collaboratively together. So I like to say when you reach out to one TRC, you're actually getting 14 trying to help you. Next slide. We have 2 more webinars planned for this series. Next week on May 14th, it will focus in on seniors. And on May 21st, we will focus in on telemental and behavioral health services. Information on how to register for those webinars will be available on CCHP's website. Next slide. Today's webinar, we will hear from 2 Medicaid programs, Georgia Medicaid and Kansas Medicaid. First up will be Georgia Medicaid, and we will be hearing from Catherine Ivey. Catherine Ivey has worked in public health care programs for over 30 years, and specifically in medical care management, home care, acute care hospitals, clinical, social work, and Medicaid program and policy development. She serves as the Deputy Executive Director of Service Administration for the Georgia Department of Community Health. She will be joined by Rebecca Duger. Rebecca has served in the Department of Community Health for over 11 years and is currently Director of Program and Community Supports, where she has responsibilities over long-term care services, including waiver programs, nursing homes, behavioral health, and hospice. Additionally, she serves as a subject matter expert for telemedicine for the agency. Prior to coming to the state, she worked for 18 years with Grady and Emory Healthcare Systems as the Administrative Director over anesthesiology, pain, and pre-admission clinics. So I will turn it now over to Georgia.
Great, thank you so much, May. Let me at least start by saying that I want to thank the Center for Connected Health Policy for holding these webinars. It's always good to be able to share what we're doing here in Georgia, but it's always important to be able to glean and learn from what others are doing so that we can all continue to provide quality service. So let's go ahead and get started. Next slide, please. Thank you. And so we always begin all of our presentations with the mission of the Georgia Department of Community Health, which is to provide access to affordable, quality health care to Georgians through effective planning, purchasing, and oversight. And as May discussed, I will be joined today by my Executive Deputy Director, Catherine Ivey, who will definitely give you some pearls of wisdom and share what we have learned during this particular time. So you guys are actually in for a treat to a certain degree. Next slide, please. Our purpose is shaping the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. And so we'll go over our agenda, and that's on our next slide, please. We will provide just a bit of background so that we can level set and folks can understand where Georgia has come from. We'll talk a little bit about where we were before the public health emergency and what our policy guidance used to look like. Then we'll talk about what actually occurred during the public health emergency and how we had to change some of that policy guidance. We'll also share with you our telehealth survey and things that we're learning as we receive those responses. And then we'll talk about what will happen post public health emergency. And then certainly we're always happy to entertain any questions and answers. And we also have a couple of polling questions in here for you because we, again, like I said, we want to learn from you and just have a little bit of engagement for today. Next slide, please. So before we get started talking about the history of Georgia, we do want to note that Georgia's population as of April of last year was 10,725,274. And then our Medicaid population as of March is 2,334,119. So we're looking at a large Medicaid population, all types of services that are being provided, all types of eligibility levels, but we are certainly trying to be responsive to the needs of Georgians. And so the Telemedicine Act actually began in July of 2005, and it includes payment for services that are covered under such health benefit policies and appropriately provided through telemedicine. And so this was something that legislatively had to be approved. And so that's how we began. We furthermore, the Georgia Composite Medical Board Regulation Practice, that particular act, and it's found under the Georgia Comprehensive Rules and Regulations. And I want to make sure I read this so that we're not misquoting, but 360-3-07. And the purpose of that is to establish the minimum standards of practice while providing treatment and/or consultation recommendations through the use of telemedicine. And the reason why that's very important is because we have to level set there and say, this is the minimum. But then when we are brought or faced with a challenge, we can certainly go above that to make sure that we are responsive. So that's just a bit of a background there. And then as we continue on, next slide, please. Georgia defines telemedicine services as the practice by a duly licensed physician or other healthcare provider acting within the scope of their practice of healthcare delivery, diagnosis, consultation, treatment, or transfer of medical data by means of audio, video, or data communications, which are used during a medical, clinical, therapeutic visit with a patient, or which are used to transfer clinical data obtained during the visit with the patient. And so also historically, we had initially had equipment, very specialized equipment that these things could be done on and so forth. And so that was very interesting in Georgia that in terms of how we defined it, because we also had included that as part of what we attempted to do. And here you have our exclusions that originally standard telephones and facsimile transmissions and as well as emails and things like that would not constitute telemedicine services. We also here in Georgia understand parity. And so Medicaid must reimburse treating providers for the diagnosis and consultation and so forth on the same basis that we would normally provide if it was a face-to-face contact. Now, I do understand that there are some states, and that's what we've learned over the year or so, that there's some differences between face-to-face as well as telemedicine. But here in Georgia, we do not. We pay the same rate regardless of how the services are rendered. And then historically, we did have a patient site requirement. The law explicitly stated that it was the intent of the General Assembly to mitigate geographic discrimination in the delivery of health care. And there was no distinction between urban and rural patients related to reimbursement, because we also know that in some states there is a reimbursement. There might be an additional fee that is set when something is administered in our rural areas. And so we did not make that distinction at all. So we wanted to make sure that everyone was on a level playing field. Next slide, please. So I'm not going to go through all of this, but of course the practice through electronic or other such means, that's identified in our Georgia Composite Medical Board, and it discusses the types of licenses that are required. It discusses the in-person examinations and things like that that a person must have, and then you can read all that for your leisure. And that also includes all of our therapeutic options that we might have. So everyone, of course, has to be licensed in order to practice here in Georgia in that particular space. Next slide, please. So the same thing with records. There is no difference with the record and how those things are maintained. The telemedicine provider must have that patient's medical history available at the time of consult, as well as the referring practitioner must also have a copy of that. The patient must receive those credentials and emergency contact information prior to the visit, and they must be clear on what will be occurring during that particular telemedicine visit, unless it's an emergency. And we'll get into that a little later as we were responding to our public health emergency. And then historically, there must have been at least some effort to have an annual in-person exam. That was very important to us, that providers would have seen the member at least one time and then acknowledge that this is the treatment plan or the plan of care. And then the member, of course, would agree, and then telemedicine would also be discussed as an option for that continued treatment. And then, of course, as we discussed, the standard of care would not alter in any particular way with telemedicine. And so all of that is very important as we think about it, especially in the space of children and what needed to occur with them. Next slide, please. So here's just a quick and simple model where we have our hospital, and then of course, before the public health emergency, all the providers had to be in one location. And then certainly if there was a two-way or interactive video and audio, then that could be delivered via telehealth. If the member was at the spoke site with another provider or practitioner, that would be allowed. And then, of course, again, if there was another type of examination of someone that's providing a consult, then that could also be provided. And those were the only ways that that could occur. So usually all of these particular models, the consistent piece here was that there was always a provider or another practitioner on the other end, relaying clinical data or some other type of therapeutic information. So that was something that we had here in Georgia, which meant that there were always two practitioners there that were involved. Next slide, please. Now, one of the things, again, as you heard me talk about in terms of rural health, we developed some things that we want to be very responsive to our delivery system in those areas where people may not be able to get to their practitioner. One of the things that we did is that where we may have a large hospital system, we partnered with those hospital systems and we allowed for the public health departments to be able to reach out to them to perform telehealth services. We also have our federally qualified health centers and to perform those visits. And so they are also partnered with us to do the work. And then we also had our schools, which is very important for the children that may receive some behavioral health and therapy services. We had schools that had specific telemedicine equipment, and that was placed in nurses' office or counselor's office and things like that. And children could actually have an appointment there at the school to receive those services. And then certainly if there was a physician that may have been in a rural county and needed to consult with someone, they were able to do that. Something else that was unique to Georgia is that we had a Wi-Fi or telemedicine equipped ambulances. These ambulances could park in a very specific location, and then you could actually have a visit, particularly if there was an emergency service that of course needed to be addressed, and it would have been, taken too long for the person to get to that facility. They could then actually administer the care there in the ambulance with that Wi-Fi connection. And then of course, we've had a long-standing partnership with our Department of Corrections, where of course, those that are incarcerated could receive the same type of care when they are reaching out to our hospital hub. And so those are just some of the examples of how we addressed our rural healthcare systems in terms of telemedicine. Next slide, please. Okay, so let's just get into it a little bit, because once the public health emergency hit, it was, of course, very shocking for us. And I'm going to let Catherine jump in here and talk a little bit about how we responded here in Georgia. Catherine?
Thank you, Rebecca. Members of the leadership Medicaid team, just like all over the country, all state Medicaid agencies responded immediately. We had to, and we developed some early intervention services. We developed some models of delivery that we would not have otherwise tried. Probably the theme of this is that we were writing 1115 and 1135 and Appendix K applications just as quickly as we could. CMS was reviewing those very quickly and approving them. So some of the things that we did were just like other states. We stopped all prior authorizations for emergency hospitalization, many other services. We completely discontinued Medicaid terminations, eligibility terminations. So, and we're still on a hold pattern about that. So the 2.3 million members that you heard Rebecca say in the beginning in Medicaid in Georgia is an inflated number, slightly inflated because of our complete hold on Medicaid eligibility terminations during the public health emergency. One of the things that we also did very quickly was we pulled out all the stops on use of telehealth. And we'll talk as we go through these next slides about what that exactly meant. Thank you. So we ordinarily required a modifier on all claims, which indicated to us that services were delivered via telehealth. So with that modifier, we were able to deliver location, et cetera. We also had providers use on the claim the place of service, which was identified, just identified that the member, the Medicaid member, was at home when the service was delivered. We decided, because we honestly did not have the time to move our system, Medicaid systems, all claim systems are slow to edit and to make significant changes to. And for us to have added the modifiers to each procedure code that we opened up for telehealth would have taken way longer than the pandemic would have lasted. And so we simply opened it up to any provider who listed place of service 02 on the claim. That simply just required the provider to indicate that the member was at home when the service was delivered. The pro to that is that we got telehealth on the ground in record speed. It was literally overnight. We posted messages to the provider in our management and our Medicaid managed information system, just saying use that place of service 02 and go ahead and bill your claims. See those members, see them via telehealth and bill the claim. What the con side of all that is that we will tell you that we have very little available in the way of what's really valid data, because we set our system in such a way that while we ask that providers bill claims with that place of service, we did not require it. The claim would not deny if they didn't do that. And so we think we have good data on the number of telehealth visits that were billed, but we're not sure. Next slide, please. The reporting at that point was honestly a little secondary to just getting folks served. So we changed everything about telehealth. The originating site, the distance site, billing, as I mentioned, consent we allowed by phone, of course, or via video screen. The HIPAA regulations, fortunately, were relaxed, and we are relying a great deal on that. And the Office of Civil Rights relaxation of the HIPAA regulations around that. And we're waiting to see what happens after the PHE is called closed. We approved providers in record speed, and like many areas of the country had to do, we opened up treatment sites in our World Congress Center, in our in large stadiums. We opened up treatment sites, and to provide services in those treatment sites, we had to approve providers really quickly from out of state. So we had that all nailed down and did that very quickly. So we, of course, responded via the Appendix K applications to CMS for our most involved Medicaid members, which were those on our 1915C waiver programs, elderly and disabled, folks with intellectual and developmental disabilities, et cetera. And we've given you a provider guidance around the policy language generally used for telehealth. We have a poll question here, so if we could just launch into the poll question, we really want to hear from you all. So the first poll question should have appeared on your screen, and we want to know from other state Medicaid agencies, did you all significantly expand telehealth in response to the public health emergency? And there are going to be follow-up questions on this because we are waiting to hear from you as well. And May, if you all will just give it as long as you think we need. Thank you. Very good. Everybody did. 89, looks like 86% of you expanded your state's Medicaid policies significantly and did the same thing we did with telehealth, just opened it up. Okay, thank you all. Next slide, please. Thank you. Rebecca, I'm going to go back to you for this one and we'll just go back and forth, okay?
Sure, that will work. So, of course, as Catherine discussed, there were several actions that we had to do when we expanded telemedicine during the public health emergency. So of trying to make sure that we are responsive to the initial topic here of children. So loosening privacy regulations, and we talked about that in terms of OCR and what they were allowing to do, allowing those phone visits to qualify as telemedicine. There were a number of our providers, specifically around our speech therapies, that felt that they could perform those particular visits using the phone and those sorts of things. And so, of course, that was certainly relaxed. And then, as Catherine discussed, allowing clinicians to practice across state lines. So there were certain types of folks that needed to be seen, and the person was in another state, usually in a neighboring state, and we were able to assist them with allowing those clinicians to come in and render those services, as opposed to going through our very long process of being credentialed here within the state. It was a much shorter process. Again, allowing patients to access services from their homes. And that also was very important for our families with children who may have needed therapeutic services. We found that they were able to plug in, log in to whatever platform was available, and that therapists could then work with that child via Zoom or whatever it was, and still they would be able to get their visit. Now, initially there was a little pushback, and we'll talk about that in the survey. But of course, once the child, depending on age, got used to working in that particular manner, they would still continue on with their visits. And so you can see some of the other things that we discussed here, just in a different format. Next slide, please. And so also another expansion that occurred, and we talked about that, we allowed our FQHCs to serve as distant telehealth sites. So if folks could not get to or did not even have the equipment they needed, our FQHCs did have the equipment and they could go there and receive services. We allowed the emergency department visits and initial nursing facility and discharge visits. And Catherine had already discussed all of this, as well as the home visits and how that has significantly changed. There was a significant uptick, of course, as everyone was quarantined. Next slide, please. And this just goes over some of the things, of course, that CMS has allowed us to change our policies in terms of how and when we conduct telehealth. And now I will say this, because we were actually discussing this, my fellow panelists, we did not make any changes in terms of going through each of our policies related to this. What we did do is that we allowed our banner messages through our Medicaid Management Information System to post all of those latest updates. So providers, of course, would be able to log in and see the latest updates and the latest policy changes. And sometimes, of course, some folks don't necessarily do that, and they will, pose a question. We did have an email box, and we still do, that was established for those kinds of questions. And we received a lot of questions from our speech and behavioral health and crowd. And they, of course, would ask those very discrete questions. And we certainly were able to work with them just so that they could understand, how they needed to code and what was actually available. And it took a little bit in the learning curve too. So that was important for us to be able to do that. But we did not change any of our policy manuals or anything like that. We just put it all within our banner messages and other things that we were doing. And Catherine and another Deputy Executive Director, Brian Dowd, as they were talking with some of our provider networks and member networks, we would, constantly go out and discuss the options that were available to them. I think initially we did somewhere around about 8 webinars and things like that. And then, of course, we began to do a very specific one for our children's intervention services. We had at least 2 of those that were centered around that, so that that particular provider group could understand what they needed to do to continue to provide services. Next slide, please. So not going to belabor the point here, but as far as the originating site, we know what the policy initially stated, that it allows states broad authority to waive limitations. For Georgia providers, that just meant that they were able to just go video or telephone regardless of the location, and again, could be in the home as long as it was deemed medically necessary, as far as preset criteria of each procedure or treatment. So there should not have been anything new that was introduced or, without that prior approval. Next slide, please. And then the same thing with the distance site. The provider usually was able to deliver medically necessary services in a variety of settings. including homes or other settings in which the privacy or confidentiality of a member could be assured. And so for our providers, again, they were able to just do that even from their own homes. We talked about that model where they may be at a hospital or within their medical office or something like that. But we allowed for them to be at home and still provide those services. And of course, they had to attest and certainly write down that that privacy was maintained, because we know that during the public health emergency, there's always might be a number of people within the household and those sorts of things. And we wanted to make sure that that privacy was maintained. Next slide, please. And so again, as Catherine stated around billing, when it's included in their homes, they had to use that O2. Of course, that Q3014 facility fee was available as applicable, and so on and so forth. So again, because I think we've said a good bit of this already. And so we have another poll question for you. And Aria, if you could bring that up, please. And Anne, we're going to answer that in just a few. Okay, so what we want to know is, does your state offer rate parity between telehealth delivery versus face-to-face? And again, we talked about here in Georgia, it's the same across the board, but we want to know what other states are doing out there. And Aria and team, you could let that go as long as you feel like that needs to go, and then we can end it now. Okay, so wonderful. So about 50% offered parity, and then it looks like some, interesting enough, and I'd like to hear from you all, the 20% and the 27% that stated no, and only during the public health emergency. That's something certainly that we can dig into later, but that's very interesting that there was that in place where not all states offered maybe perhaps a hybrid payment model. Next slide, please. And so again, good faith modes of communication. We're very curious about this because it was supposed to, oh good, thank you Kendra for chiming in with that. That there's a difference between fee-for-service and her Medicaid plans in terms of payment structure. There was a lot of different hybrids in terms of how information was passed on. We have very large health systems here in Georgia, and sometimes they have their own patient portal. And so that's what we're meaning by the written communication. Sometimes you can log on and have a face-to-face conversation, and then you're one and done, or you could be chatting with a nurse and that sort of thing, and also have your visit, and we allowed that. And then of course, telephonic, which historically was not allowed, as well as the live interactive, which is what we really was trying to make sure that most people were able to do during their visits. Next slide, please. So what wasn't telemedicine? Of course, remote education and technology for research, those types of things. We did get requests about public-facing social media or healthcare professional practitioners that were doing all kinds of things and similar to that. And Catherine, did you want to speak to that? But I can give you an example. You had providers that were kind of doing therapy in mass or whatever, and they were wondering if Medicaid, I have a few Medicaid members, can you reimburse for that sort of thing? And we were like, no, and all of that. And one of the other things that we saw was that some states allowed this, and even some commercial entities allowed. We did not recognize the e-visits and the digital evaluations or virtual check-in. So we didn't even open the codes for those. So I know that some states did, but Georgia did not. We felt that you needed a complete visit for that. And so we didn't open up those. Next slide, please. And again, same thing about what wasn't permitted. Next slide, please. So I want to be cognizant of the other states' time there. And so getting back to our question that was just posed. So after the public health emergency, where do we go from here? And Catherine, I am going to allow you to dig into this one because you were the author of our survey. Catherine?
Thank you, Rebecca. Next slide, please. We knew early on in the public health emergency that we really needed to hear from providers and members. We had so expanded telehealth overnight that we really needed to hear about individual experiences. And so we developed a survey which we put on our Medicaid website, the Department of Community Health website. And we specifically asked providers and members, and we opened up a category for advocacy groups also to respond. We had, for example, in Georgia, quite a number of behavioral health advocacy groups that wanted to make a statement about how well telehealth services had worked during the public health emergency. So we asked, and the whole purpose of that survey, of course, was to figure out what we should keep after the pandemic was over and what might need to revert back to just a face-to-face allowable model. And we also wanted to hear if there were things we should have opened and didn't. So next slide, please. We got quite a bit of feedback, a little bit more than we were surprised. It was a little bit more than what we were expecting. We got over 900 provider responses, and we were hoping for more member responses, but we got 130, which we took and gratefully. Next slide, please. It was a short survey, and we were curious about what types of providers were most likely to respond and did respond. And so you can see that the vast majority of responses, the provider didn't identify what type of provider they were, but the most frequently named provider type were behavioral health providers, who responded at a rate of about 30% of the total. We did have quite a number also of therapy providers, and it should be said at this point just quickly that most of our children in Georgia are served through our managed care organizations. We have a split model, like many states do, where we have some populations still using a fee-for-service Medicaid reimbursement model and other populations using a managed care model. All of our low-income moms and kids are in Medicaid managed care, as are our CHIP children, in which we call in Georgia Peach Care for Kids. It's our children's health insurance program. All of those populations are all found in managed care, along with some others. Only our age, blind, and disabled population are found in the fee-for-service model still in Georgia. And so while that doesn't necessarily influence the survey, it does influence, I think, a bit about the types of providers that we heard from, because the therapy services providers and the behavioral health providers, really, as well as the federally qualified healthcare centers, are just as likely, more likely to see children in managed care than they are in fee-for-service Medicaid. Next slide, please. 101 providers out of 910 submitted comments. So we just asked a very few number of questions that were that provided a yes/no response or that sort of thing. And then we asked for comments from those. We got quite a number of comments also from the members and parents and caregivers. So let's take a look at them on the next slides. Next slide, please. Thank you. So they really varied from very, very positive comments that telehealth should continue, all services should be available, all patients should be eligible for telehealth. And there were some member responses who really appreciated the opportunity to continue to get their medical services just as they would have before, but in their own homes, where there was almost no risk of exposure at that point. And so if we could take a look at the next slide. Thank you. We were also extremely curious and interested in the negative responses in the survey results. And I will tell you that we saw some trends in that. One of the trends we saw is that in our therapy services that are often provided to children who may have developmental issues and need occupational therapy, speech therapy, et cetera, there were quite a number of comments from parents who said that telehealth for particularly young children under age 4 seemed to be the trend, was not very effective. And it was not very satisfying to the parent or the child because the child just didn't really understand what the purpose was. And so that's sort of on our radar to evaluate as we decide going forward what the future of telehealth is going to be in Georgia. There were physicians who said that initial physician assessments should really be done only with video visits or face-to-face, that telephonic physician assessments, particularly initials, were just not effective. Crisis assessment, as you can imagine, was difficult by telehealth, but we did what we needed to do, just as everybody else in the country has done. We have a significant problem in rural parts of Georgia, in particular with access. So where there was not broadband access, it was absolutely unavailable to many families. So I think that's enough of a synopsis, and let's move to the next slide, please. Thank you. So our takeaways and our thoughts about the future, and we do have a survey, a poll question for you about this, is that telehealth is an extremely useful tool. And while we do not intend to roll it back to the way it was in Georgia, we are considering each specialty and each service and reviewing those to just determine if it's in the best interest of the member. Some of the tools that we're using are feedback from the survey, feedback and articles and different kinds of research materials that we've received from professional groups that validate the use of telehealth or point out its pitfalls. And so we're also watching very carefully the Office of Civil Rights HIPAA regulations just to see how much we have to tailor back. So we don't know whether or not telephonic with no video capacity will continue to be allowed by the Office of Civil Rights, but we'll see. We're looking at health and safety requirements and what exclusions there should be to particular services. Next, let's go to the poll question, please. Okay. So what sorts of evidence or sources, we're curious, are you looking at in your state toward guidance on an effort to either determine to roll back some of the services or continue telehealth in its current expanded version? And we really want to know, did you all do state surveys? Are you relying on Medicare and Medicaid guidance from CMS? Are you looking at private industry standards? We've heard a good bit about that. So excellent. So most of you are doing exactly what we are, which is looking at Medicare and Medicaid guidance. A few of you are looking at private industry standards, and we are as well. We're looking at some of those. So thank you for that. Okay, next slide, please. Okay. This is just a disclaimer that we pulled off of the CMS website, and we'll probably include it in future versions of our telehealth policy, that because we're constantly reviewing available evidence about whether or not telehealth is safe and effective and medically beneficial. So we liked this disclaimer and decided to throw it into the slide presentation. Next slide, please. Okay. We also have been working, as Rebecca said, a great deal with our public health agency. The Georgia Department of Public Health is the lead agency in Georgia for the COVID-19 public health effort and public health information. And they just did begin to open up in-person visits to vulnerable families. This was particularly relevant to the services that they provide to families and children who are very young, 0 to age 3, who are medically fragile or require services for developmental delays, et cetera. And they are looking at the following criteria to determine which are vulnerable families and which are not. So they're looking at internet and technology challenges, for example, as we mentioned, are inherent in many parts of Georgia. Medically fragile children based on diagnosis, parents of children who are deaf or hard of hearing. Obviously, telehealth is not going to be the best option, may not be the best option for them. Families who live in shelters because there's very little opportunity for confidentiality and privacy. Children who need, of course, measurement or fitting of adaptive equipment, which just really can't effectively be done via telehealth. In-person modeling or positioning or feeding strategies that really need to be done face-to-face, and an assessment that requires an in-person administration. We heard that some from psychologists who were providing, say, for example, autism psychological evaluations, and really needed to be able to conduct some portions of the assessment that just couldn't be done via telehealth. So next slide, please. Okay. We gave you some citations at the end that we found helpful during our walk through this public health emergency. And so you have that. Next slide, please. We want to encourage you to reach out to us if you have ideas, if you have citations, if you have information that your state is using to determine how far back you may roll telehealth versus how much you're going to keep in. There's very little opportunity actually for state Medicaid agencies to just dialogue. And I've often said maybe in my retirement, I'll set up a blog site for state Medicaid agencies, employees to just talk. And so we want to invite you to email us if you have ideas or you're struggling with the same issues. Thank you very much.
Thank you, Catherine and Rebecca. And Catherine, I love your idea of a blog, or at least some sort of maybe coffee room where the Medicaid staff can like just talk from different states as well. Maybe it's something that CCHP can help with. That's one of the reasons we are doing these webinars, is just to like help facilitate that discussion in some way.
Thank you.
Yeah. So
I'm going to take that as an offer.
Okay, we'll talk offline. We'll see what we can do. Rebecca, if you wouldn't mind maybe putting your camera back on as well. We've got a couple of questions for you guys. The first one is from Carl Guyden. Since Georgia Medicaid gives its guidance to CMOs with regards to rules and regulations, how are you helping the CMOs to reshape their telehealth policies?
Ultimately, the CMOs follow our guidance in fee-for-service. So our CMOs operate as a beginning point with our fee-for-service policies and guidance. And we had in the beginning of the pandemic, we had weekly conversations where we brought the CMOs together and we talked about what we were rolling out with the expectation that they would do the same thing. As the PHE has rolled on, we've relaxed that a good bit. And we know that we're all sort of moving into what may be our new normal. But at this point, it remains always that the policies for fee-for-service are the baseline, the benchmark for our managed care organizations.
I think I know the answer to this, but I'll put it to you. It was mentioned, I believe, in your presentation, but does Georgia consider e-consults, two providers consulting with each other, to be telemedicine?
No,
Rebecca?
No, we do not. We did not open up any of those codes related to any sort of e-consults.
Okay. And we'll take one more question because we still do have Kansas waiting in the wings. Will the state be taking steps to better understand the validity and completeness of data questions that Ms. Ivy mentioned, or taking steps to improve it? Are there any challenges for doing so?
We definitely are in that place right now where we need to begin to correct what we did as an absolute emergency response at the beginning of the pandemic. we know from this point forward that we have got to develop a way to collect data very effectively and be able to report on that data in terms of the numbers of visits that are done via telehealth. Ultimately, we would roll that into our HEDIS measures and look at outcomes based on those services delivered via telehealth, via those delivered face-to-face. How we do that is what Rebecca and I feel is at this point the $1 billion question. And so that remains to be seen. It will have to be attached to the procedure codes in each claim somehow for us to be able to do that. But we're trying to decide the most expedient and effective way to do that at this point. So that's just where we are.
Okay. All right, thank you very much. Both Catherine and Rebecca will be back later when we have our all panelists Q&A session, but right now we're going to transition it over to Kansas. And we have with us today Fran Seymour Hunter, who is an RN with a BSN and MS in counseling. She's currently employed with the Medicaid Division of the Kansas Department of Health and Environment. Within this position, she serves as the interagency liaison for other state agencies who access Medicaid funding. Also, among other assignments, she also has the assigned program area of telemedicine coverage. She's joined with Brenda Cooter, who has been an RN for 36 years. She works for the state of Kansas for 34 years, 12 years as program manager or senior manager in the Medicaid office, and retired in 2011. She returned to state employment in 2017 as nurse consultant to the Medicaid program and currently works 2 days a week. She's worked with all programs within Medicaid, but her emphasis has been with school-based services programming. So I will now turn it over to Brenda and Fran.
Thank you. This is Brenda, and I'm going to talk specifically about the Medicaid school-based services in Kansas. And then Fran will come on later and talk about the telemedicine services. Next slide. I wanted to give everybody just a little bit of the Kansas demographics. Our population, we are a little over 2.9 million, and 14% of that population is covered under our Medicaid or our CHIP program. Our monthly caseload average for all Medicaid populations is a little over 408,000. And we are one of those states that has not expanded Medicaid. There's been a lot of discussion, both last session and currently this session, but a determination has not been made yet. We have 105 counties in our state, and 66 of which meet the definition of being medically underserved. Our current budget for the Kansas Medical Assistance Program is $3.8 billion, and approximately $10 million in school-based services is paid out annually. Next slide. The history for our school-based program is that we have paid for services in a school setting since 1997. Initially, we paid for those services through a traditional fee-for-service code billing method. But quickly, we moved to a bundled rate methodology, and it was a code that was based on the child's exceptionality. There were approximately 9 codes, and they were for developmental delay, autism, physical disability, any of those specific exceptionalities that the child might have. However, that was cumbersome for our providers, and we continued with that for about 10 years. And the providers enjoyed that billing process. They did not like the fee-for-service. However, we were audited by OIG in 2004. And they looked at our fiscal services that were paid out from 1998 to 2003. And although I wasn't here when the bundled rate was developed, I was here when OIG came in to do the audits. And they looked at a variety of things with our bundled rate. They looked at how the rate was determined. They looked at how the rate was applied. They also looked at how the services were delivered and the documentation of such, and really looked at the entire program. So unfortunately, after we got done with the audits, we then returned to the traditional fee-for-service codes because the OIG audit did not agree with how the rates were determined, how they were applied, and oftentimes a child might only get one service a month, but they would get that entire rate for that entire month. So that's why we ended up going back to the fee-for-service codes. And for the state of Kansas, providers include both the school districts and our infant toddler services network providers, or in Kansas, they're called early childhood intervention providers. That is what we consider our school-based services providers. Next slide. So the services that we have currently at that time, without the telemedicine piece, with the services that were reimbursed in the school setting, we had our health screenings, our occupational therapy, physical therapy, skilled nursing services, speech language therapy services, transportation services. And this was not for the yellow school bus. This was for a child who might need medical transportation, a wheelchair accessible bus, those kinds of things. And also, of course, vision services. Next slide. And these are the services specific requirements. They really don't differ from, that's not changed in all the years that we've done school-based services. The service must be medically necessary. It's intended to yield the maximum reduction of disability and restoration, meaning that we need to see that forward progress of a reduction of a disability or improvement in the child. All services must be included on the child's IEP or IFSP. Some individuals may have a physician plan, but most of our kiddos have an individual service plan or an IEP. And one of the things that came out of the OIG audits was that we didn't always have doctor's orders for all of our therapy services. And so that was a change, that we now have to have a physician order for all therapy services as documented on the IEP. Next slide. And even though Kansas actually allowed telemedicine as a service delivery back in August of 2004, it was not an allowed service delivery method for school-based services until January 1st of 2019. There was a Kansas Telemedicine Act that was put forth before the session that was approved, and that opened up school-based services on a very small allowance for telemedicine services. And specifically, the telemedicine services were limited to speech language and audiology services, and only to a specific set of codes that was found in either the local educational agency manual or in the early childhood intervention provider manual. However, with the public health crisis that occurred in March of 2020, we expanded telemedicine for not only schools, but also for a lot of other providers. But when the kids were not able to be in school, we realized that there were definitely services that they would need to continue, so we didn't have any regression. And so we pretty much did what Georgia did, in that we went in and opened up a lot of services to be allowed via telemedicine. And so for the schools, it wasn't just for speech, language, and audiology. We opened it up for nursing services and for all the therapy services. And we allowed some consultation codes to be allowed through telemedicine, and also telephonic as well. Next slide, please. One important thing that we realized as we were moving forward with the expansion of telemedicine in the school setting was to work with our counterparts in the Department of Health and Environment in Kansas. We worked very closely with the Bureau of Family Health, and then also the Children and Families units, because those are the agencies, that's the agency that works with the local educational agencies directly and the ECI providers. And they're very knowledgeable in what those schools needed or what those providers needed in order to be able to continue to provide services for our children. And we also worked with the Part C Tiny K, and we worked with the Department of Education as well. Next slide, please. And really, when you look at what services are allowed now in the school setting versus what was allowed before, we have pretty much opened up all the services that are available in a school setting to be done via telemedicine. Next slide, please. And I'm going to turn this over to Fran.
Thank you. I'm going to kind of repeat just a little bit of what we had in earlier slides. Kansas is the 15th largest state within the 50 states, and therefore we have a variety of regions, including urban, but we also have quite a few frontier areas as well as rural areas, which means that, as we stated earlier, we have 66 of our 105 counties that are designated as medically underserved. Provider access is sometimes difficult anyway, but the pandemic really crunched that quite a bit. So we tried to be as flexible basically as we could be. We did have, of course, the usual requirements that we have to as terms of Medicaid reimbursement. They have to be enrolled. The beneficiary had to be eligible. It had to be a covered service. We had to give permission for them to do it via telemedicine. We did state that we expected them to be HIPAA compliant. However, we're going to be kind of like at the national level. We're not going to be as stringent, but we also did not want to give a lot of allowances that then we were going to put people in a bind that were used to telemedicine and then had to have it rolled down because they weren't using HIPAA compliant platforms. So that was kind of deliberate on our part. And then, of course, you know, the usual in terms of the documentation. So all the things you would expect with anything that would be touching federal reimbursement through the Medicaid division. Next slide, please. We do provide the same reimbursement rate as if they were doing a face-to-face. Some of this, of those of you who've been doing telemedicine for a while, is not going to be, you know, anything new to you, but we do pay for the Q3014 at $20 at the originating site when the provider and practitioner is there. We did open up home because, again, as Brenda stated, some school was not in session. And so some of these services were being provided to individuals that were actually at home doing virtual education. So we did allow that, but they, of course, could not bill the Q3014 unless a provider or practitioner was actually at that site. We did require, and the MCOs have done a degree of auditing on this. However, the ECI and LEAs, interestingly enough, in Kansas are not a part of our managed care organizations. So we needed to figure out a way to really know how much telemedicine was being provided. So we did require that if they were doing telemedicine visits, that they needed to put in the O2 indicator for place of service. Next slide, please. We are just kind of starting some of our feedback. We've had already some stakeholder meetings. We are eliciting a lot of feedback from every place that we can get it. Our legislators are very good about letting us know what they're hearing from their constituency. And overall, the perception is that it's been well received, particularly since this is emphasizing the ECI and LEA programs, that it's been very well received for providers as well as the students and families that they are serving. We know that we need to continue with communication with our other agencies so that we can stay in step with them and see what may be needed as we move forward. Hopefully we'll all get to that point where we will get a new normal when some of the restrictions from the pandemic are lifted. Next slide, please. So we are just continuing on with telemedicine when we have opened them up for these particular services, ECI and the LEAs. We get a lot of questions, and I've already seen some in the chat. Every week in the position that I'm in, I get an email, a phone call, when are you going to roll it back? And what we have basically told folks is that they will get at least a 60-day notification if we would elect to roll some of these back. What we did originally, not having any idea that the pandemic would last as long and be as robust as it has been, originally we had corresponded our policies with what our governor's executive order stated, which would have ended all of them May 1st back in 2020. But it became very, very obvious as time rolled on that that was not going to be a time in which to roll back because things kept evolving, which I don't think any of us in March knew. And so most of our policies, we basically put down that they were in effect until we officially rescinded them. But we still get lots and lots of questions about when will this be rolled back. And like I said, we've communicated to the provider groups, the stakeholders, the advocates, that we will give a minimum of a 60-day notification before we roll any of these back. So we're going to be doing a lot of work with stakeholder groups. We will be utilizing feedback from our sister agencies, family feedback in any form that we can get it, to kind of figure out the positives, the negatives, and what services might be better with a few more guidance around it, like what Georgia had originally talked about, where, okay, you can do telemedicine, but the initial visit needs to be done in person, face-to-face. Certain services, even though we've allowed some of them by telephone, are we going to allow that to go forward? So there are lots of things that we will be looking at and taking into consideration. And the next slide. We did give you a couple of links. Our provider manuals are online and open to anyone. And for this specific presentation, the local education agency manual or the early childhood intervention manual are where you'd want to look for kind of specifics on that. And again, like Georgia, we did not try to embed all of the codes that we opened up for the pandemic. It was going to be a lot of work, and a lot of staff were either not working or working remotely. So what we did instead was, through our bulletin process, we created a section, which is noted here in that www.kmap link that you have there, that are specific to telemedicine, which would tell you not only for the programs that we're talking about today, but for some of our other programs, whether it's allowed via telemedicine, if it's new, is it allowed in the home? Do we allow telephonic? All of those sorts of things are kind of embedded in that section on the KMAP site. And what we neglected to do, and I think it was just an oversight on our part, like Georgia, we would welcome contact from anyone that would like to reach out for us. And May, I don't know, should I put that in the chat, our email address, or how would that be best to get to folks?
Yeah, you know what? We can put that in the chat. You can also contact CCHP, and as long as I have like Fran and Brenda's permission, I can share those emails too with folks as well, so that you have a couple of routes as well and how to like reach out directly to Kansas Medicaid.
And that's the end of our presentation.
Okay, great. Thank you so much, Fran and Brenda. I actually have my first question is actually my question. Brenda, you had mentioned that prior to the pandemic, the services that were allowed from the school-based system via telehealth were very limited, but you obviously opened it up during the public health emergency. Did that create issues? Because what we noticed when things did open up during the public health emergency for telehealth, people weren't necessarily prepared for that on their end. Like they were not used to like offering certain services via telehealth. Did you find your school programs, the school-based programs, running into those issues that they weren't necessarily prepared to take advantage, at least initially, of like all those flexibilities that were first given?
Well, I think that since the Kansas Telemedicine Act was put into effect in early 2020, or actually early 2019, schools had already started to build up their systems in order to be able to provide services via telemedicine. And so they were able to jump right on and start providing services. We didn't really have any issues with any of the schools saying that they didn't have the connectivity or the systems ready. They were pretty much ready to go.
And what a lot of the schools did, even prior to the pandemic, was a lot of the schools have done some transitioning into issuing laptops for their students. And so a lot of school districts already had laptops for their students. And a lot of the school districts, there was a run on laptops, and I know they ran out, but a lot of them went ahead and provided that for their students, which again helped some of the access. But again, like a lot of places, broadband was an issue in some parts of our state, which is part of our rationale for allowing telephonic. The other thing that we found, which was really interesting, is that in some cases, the kids were doing virtual, the parents were working from home, and it was their internet at home that was creating the issues for connectivity, because they had to kind of space some of that out. And so there were just kind of some interesting things that came out regarding all of this.
Yeah, that was probably very key, that you had a lot of schools that already had issued laptops already. So they had that for their students. And you're definitely right. I know nationally there was a run on laptops and such a shortage in the beginning months of COVID.
Yeah.
So we've got a question from Kelly Wolf. Are schools using ESSER dollars to increase some of these services, especially for mental health, etc.? And I admit I am not familiar with ESSER dollars or ESSER dollars.
I'm not either. Are you, Fran?
No, I am not.
Yeah. So Kelly, if you wouldn't mind maybe like doing a clarification, we can circle back to your question on what exactly that means. Allison Bauman, and I apologize if I'm mispronouncing your name, asked, in 2014, states were given the option of expanding Medicaid to pay for medically necessary services in schools for beneficiaries, even if the individual doesn't qualify for an IEP. About 15 states or so have taken up this option. Is Kansas considering this?
Not at this time. We are continuing to require the child to be Medicaid eligible and to have an IEP or an IFSP and to have those services listed on those documents.
Okay.
I can add the Georgia perspective on that if you like.
Yeah, go ahead.
We offer, just exactly like Kansas does, a laundry list of services in our Children's Intervention School Services program. And those are delivered through partnership with the local education agency. So the local education agency hosts the telehealth delivery or the on-site delivery, to be honest with you. So the entire thing. We've been working for quite a while now with CMS on a state plan amendment that expands school nursing as part of that laundry list of services. The one that we've really focused on right now is school nursing services, and it would expand that to children who are not covered through an IEP.
Thank you, Georgia. And Tammy Alexander, thank you, clarified that ESSER is elementary and secondary school emergency relief funds. And Kelly followed up her question with a little bit more detailed. ESSER were the dollars for K through 12 included in HR 133 and the American Rescue Plan. They can be used to target learning loss, children with special needs, and mental health. That it may be a little bit too soon, I think, for our speakers to speak about funds that are coming from the American Rescue Plan. And there's still, like, I think, a bit of process of like getting from the federal government to the state government and then eventually to Medicaid. So I'm not sure if our speakers are able to like answer that question now, just because of the timing of like how soon that was.
Yeah, I'm not able to for Kansas. I don't know if Fran is or not.
No, I know. Now that you explained that, and I apologize, I know there's been some discussion, but how it impacts us, I'm not aware.
I don't think Georgia could answer that either.
Yeah, it takes a while. I mean, it's great that they passed it in Congress, but it still takes a while to filter down to the states and for them to sort it out. So thank you for that question, and hope, you know, maybe we'll have some answers like later on in a couple of months or so, or a couple of weeks or so. Now, this is an interesting question. It's from an anonymous attendee. What will be your process for figuring out what could or should stay? Any evaluation of this prior to rolling back? And I know Georgia talked a little bit about that. So maybe Kansas, you might want to start us off. And if Georgia, if you want to add some details, feel free.
Well, as I indicated, we've already started some of that. We've talked with advocacy groups. We have stakeholder groups. It doesn't impact ECI and the LEA programs, but we are utilizing our managed care companies. In Kansas, 98% of our Medicaid population is assigned to managed care. They are helping us with the data in terms of what they're seeing. Again, it's not specific to what was our presentation because we focused on ECI and LEA, but a major uptick, even though it was widely used before with behavioral health, an even greater uptick in the behavioral health arena. And so we are getting input from all directions and trying to keep track of all of the feedback that we're getting. Legislative feedback, stakeholder groups that have been convened, advocacy groups have contacted us, associations have contacted us. We're just getting all kinds of feedback, and we will probably, you know, perhaps as it gets a little bit closer, because we really anticipate this will go to the end of the year, you know, that it might be a more systematic approach, but we've already been gathering a lot of information and compiling what we're hearing, the positives as well as the negatives, because there are some people that do not want to access this even if we allow it to continue. They really want to go back to face depending upon the service, but it's kind of individual, you know, in terms of their own comfort level with it.
I think I would be remiss if I didn't add that for quite some months now, CMS has been concerned about the vaccination rates of children. And we've all Medicaid agencies have been getting correspondence from CMS specifically requesting that we follow up with the pediatric community and with our members to the extent possible to convince them that they do need some face-to-face visits, because last I checked, you can't receive a preventive vaccination by telehealth. And so we are pushing it in Georgia. We've got all of our managed care organizations in Georgia putting out messages to members to remind them that it's so important to have children vaccinated for all manner of preventive diseases. And so that's been a big worry at CMS. And so I think we're just all very cognizant of that.
Mm-hmm. I'm going to offer sort of one suggestion that I've heard from other Medicaid programs as far as some survey data that they are looking to get in order to help inform them on their decisions regarding future telehealth policies. And they have said that they may be working questions into their CAPS survey. So that is one route a couple of states have decided to take, is like trying to get some of that more sort of enrollee type of information and their feedback, as well as by having certain questions worked into their CAP survey. And I see you guys nodding your head. I can like kind of put you in contact with those states that I know that have like started talking about doing that. Maybe first topic for our like coffee Medicaid Zoom thing, their capper that we were talking about earlier. It's like, how are you doing this in your CAP survey and what are you asking?
There's our blog topic, right? We'll take it.
Blog topic. Yeah. All right. We got another question. Are Georgia or Kansas working with AAP chapters on vaccination for children?
That's really our go-to in Georgia,
Mhm.
is the Georgia chapter of the AAP. And they work very closely with our managed care organizations in Georgia. We have every other month meetings with our Georgia chapter, and we've been working together with them on this for months, ever since it came to our attention through CMS. I will say that from our experience working with the Georgia chapter of AAP, there are mixed feelings about telehealth, probably largely for this reason.
Mhm. Okay, and we have a question from Dr. Marston at UC Davis, who CCHP knows very well. I'm actually not sure if you guys will be able to answer this, but I'll put it to you anyway. Would love to hear which of these many programs are most successful. How many schools, how many kids per week, how many local pediatrician specialty offices. It's great to hear about how telehealth can be used, but would be great to hear which models are financially sustainable, successful. I don't know if that's information if you guys actually have or know about, but do you have any insights as to what has had like sort of a positive reaction as far as like certain programs such as school-based programs?
Well, I know from the state of Kansas that I would say the majority of our unified school districts are offering telemedicine delivery of services. And I think that they enjoy having that as an option, and they really appreciate having that as to be billed and paid the same as a face-to-face visit. And I know they are really trying to push us to continue it for as long as we possibly can, because they really have enjoyed having that as an option.
Mm-hmm. Yeah, I think pretty much everybody would say it needs to at least be an option. It shouldn't be mandatory, of course. And of course, there's certain things that you cannot utilize telehealth for that really does require that in-person touching aspect of it. So we have a comment from Fazia Eskew, who just says the Georgia AAP appreciates the shout out from Georgia Medicaid. We appreciate our collaborations with you as well. So we actually are done with the questions from our audience members. If you do have a question for our panelists, please type it in very quickly into the Q&A box or to the chat box. I'll monitor both at this time to see if this will be your sort of last opportunity with these great speakers, at least for this topic. We will have Kansas back for the mental health topic in about 2 weeks. So Fazia also put into the Q&A box for those who are interested. Annual well visits from AAP and AmChip via telehealth. It's a resource that he is offering for our attendees as well. So thank you, Fazia, for that. It's great that people and attendees are also sharing information that they have as well with others. But anyway, I just want to take a moment, if there are no more questions from our audience members, to thank Fran, Rebecca, Catherine, and Brenda for their great presentations. Thank you so much for taking the time to do this. We really appreciate your insights and the knowledge and information that you brought to us today. Thank you also to our attendees for being and showing up and asking such great questions. Next slide, please. This webinar is being recorded. The recording and the PowerPoints will be made available on the CCHP website a couple of days afterwards. We are also sending out, once you log off of here, an evaluation form. It really helps us as you fill out that form just to know, how you like this webinar and what are some maybe future topics you would like to see in some of the future webinar series we plan to hold. Next slide. Our next webinar will be on seniors and telehealth Medicaid policy. We'll hear from the California and Connecticut Medicaid departments. The registration information is available on the CCHP website. It'll take place on next Friday on May 14th, 11 a.m. Pacific, 2 p.m. Eastern. Next slide. And that is actually it. Once again, thank you to our great speakers today, Brenda, Fran, Catherine, and Rebecca. You guys were wonderful. Thank you also to our audience members for your great questions and for attending today's webinar. My special thanks to the CCHP staff for helping pull this together, and to Ari Javidan from the National Consortium of Telehealth Resource Centers. And everyone, I hope you have a great day, stay safe, and thank you once again for attending the webinar.